This section is designed to focus on when your client comes to you with joint pain, when they say, I have arthritis, I have this, what can I do? Or more often, hey, that new cryo sauna thing just opened up down the street. Should I do that? And 90% of the time, our answer, what the evidence in our clinical practice says, is the effectiveness of resistance training for a lot of these individual things. But people are looking for adjunct therapies, and what can they do that is not silly bullshit? And can we, using the research literature, find what is silly bullshit and what isn't? Because it is just as bad and unprofessional as us as coaches to go, oh, it's all silly bullshit, if in fact there are things that could be useful for our training populations. This is the fun part for me, just, one way or the other, looking through the literature here. Let's start with warm-up. Warm-up is one of the most common interventions used it's claimed to reduce joint pain, to reduce DOMS, to reduce really anything else. The story, because so many of these interventions have a narrative as to how it's sold and why it's justified, it prepares the athlete physically, so physiologically it increases body temperature, does all these wonderful things. It prepares them psychologically for the training that's about to happen, and everyone does it. We've done it since we were in high school. Everyone does it, so clearly it must work. Let's look at the state of the research. Actually, believe it or not, surprisingly not much when it comes to joint pain. When it comes to joint treatment and DOMS, there is a decent amount, but not nearly as much as you see in terms of performance. Not nearly as much as you see in terms of how does it improve your sprint time, how does it improve your strength. Hugely heterogeneous method. So when it comes to warm-up, what type of warm-up are they using? Is it general? Is it specific? Are they doing the movements that they actually test? Or is this, I'm going to hop on a treadmill for 5 minutes and then I'm going to test your leg extension strength? And then the usual suspects, small sample sizes, we'll get into that. It's fun. So findings, just going into the definitions and how they're used in literature, often it is not even described or it is not even defined or justified why they choose to warm up in this way. Oftentimes a warm-up is just said, and the control is they did what they normally do. Passive vice active, there are some studies done on passive warm-up techniques, things like sitting in a sauna for 5 minutes to raise body temperature. I effectively rejected those because most of our clients are not looking for those interventions, and that's a whole nother can of worms research-wise. Now, there's a good bit of research on this. I'm going to stick to and highlight just a few as kind of representative samples. We've got Safran et al. Safran et al. is an in vivo study, but done in animals, done in animal models, specifically rats. Warm-up appears to resist muscle rupture. So in this case, they actually placed the animal model, had it go through multiple contractions, multiple muscular contractions, and then essentially force muscle rupture through a mechanical intervention. It is a useful piece, but when it comes to its actual applicability to patients in the field or clients in the field, we don't really know. Thacker et al. Is one of the best in terms of research reviews for warm-up and stretching, which we talk about later. Their conclusion is that there's no strong evidence, but there is high physiological plausibility. So there's a lot of good reasons to believe that warm-up would prevent joint pain, that warm-up would reduce DOMS, that warm-up would help resist injury rate, raw injury rate. But at the very least, there's a strong plausible mechanism. Woods et al. Is another research review that comes up very often, and it comes down unequivocally on the side of research, on the side of warm-up. The warm-up is good. Warm-up prevents injury. Unfortunately, in the section where they make that conclusion, they actually only cite one study, which is Bixby and Jones in 1992. Bixby and Jones is a study of football players over the course of 55 games, and it measures their third quarter injuries. One group of high school football players does whatever they normally do during halftime, and another group does I think it was a 6-minute intervention of warm-up and stretching before they go into the third quarter. And which one sees more injuries? Well, you had 108 injuries total for 55 games, total, the entire game, and now you're going to measure just musculoskeletal injuries and joint injuries, and you're only going to measure them in the third quarter. So I'm taking 108 data points, cutting them by a quarter, and then cutting them even more because only 38% of the injuries in the third quarter were actually joint or musculoskeletal injuries. It's just not good data. You also see nowadays, there are actually multiple studies. I found 9 on neuromuscular warm-ups. These are proprietary warm-ups, usually sold by some company it incorporates plyometrics and stretching and strength training and HIIT in this, designed construct. Most of the reviews actually found some positive effect of these types of warm-ups on injury prevention. But in most of these systems, you have some element of strength training. So if I have, and at the very least, you have normal body weight movement. So if I have 30 minutes of flailing, or 25 minutes of flailing around and 5 minutes of strength training, or some kind of work up in the movement that I'm doing for that day's session, then am I actually getting 30 minutes of work or 5 minutes effective work and 25 minutes of silly bullshit? There's really no way of actually separating out that data. Now, it makes it sound like I'm actually like I'm coming out pretty negative against warm-up. Not at all. Based on the research, do it. It is almost unequivocal that it improves performance. And one of the things that we just generally see in the field is that if you improve performance at a high capacity, if you improve somebody's performance, if they can do a 400-pound squat, a 200-pound squat is not as difficult as it is for somebody whose max is a 202-pound squat. That's obviously an over-exaggeration, but I can at least see the plausible mechanism. It assists in performance. Some of the research shows a small but moderate likelihood for the improvement or for the reduction of joint pain and injury, and we already know how to warm up. Stretching. This one gets a little bit more wily. So the story, there are some different justifications offered. Does it change the tendon? Does it change the connective tissue? Does it increase joint range of motion? So if I can actually get into the range of motion for the workout, if I can get my hips down in my squat correctly, and I have enough flexibility to do so, then I'm not contorting in some weird way to get down there. And then to increase passive range of motion. So, I slip and slide on a surface that doesn't have good tension. I go into a passive stretch. That leg reaches strain passively. The tissue is actually extended without an active contraction from the muscle on the back end, and then all of a sudden I have to catch myself. I'm practically in the splits. I go to contract and stop myself, boom, and now I take a tendon that is already near the end of its reach and put a contractive force on the other end. State of the research. This one's actually well researched in terms of injury. Hugely heterogeneous research targets and methods, but at the very least they describe them well. Every study that I found said we did 30 seconds and 45 seconds, and these were the movements, and that's useful quality. Unfortunately, oftentimes different from what we actually do in the field. So in vitro tests or in animal models show plausibility. There are 2 studies, Teramoto et al., Rosetto et al., where they essentially take ligament, I think it's ligament in Rosetto, and I think it was tendon in Teramoto. But they take connective tissue, they put it in a stretching device, which anchors both ends, and they literally just stretch it to a fixed strain, and then take it back, and then stretch it to a fixed strain, and then take it back, and then they just stretch it out until finally, boom, the tissue ruptures. Anyone who's familiar with mechanics has seen that done with steel. Very similar concept. Teramoto et al. Found that little benefit was seen beyond 45 seconds, but there was some benefit even from this kind of cold mechanical manipulation. Rosetto found a similar benefit at about 2% strain. Interestingly enough, they found the 3.5% strain, so we stretch it, we follow different protocols, and then we try to rupture the tendon, it ruptures earlier. So you can't, the plausible mechanism here, the narrative that they come up with, is that you can do too much. In vivo, when we're actually dealing with patients in the field, kind of ambivalent. Thacker et al. Has a lot more to talk about here, but one of the things he points out is that flexibility. So I take someone's end range of motion, I take someone's joint all the way through, and I find out how flexible you are just by the classical tests. And then I check it against your rate of injury in different sports. I check it based a number of things in different studies, and there is not a really good correlation between range of motion and injury. And in fact, there are numerous plausible mechanisms for why, when you look at the bell curve, it is the most flexible as well as the least flexible that get injured most often. Ooh. So the person who goes to yoga twice a day, and can do I don't even know what animal it would be where you put the leg behind your head, is that productive flexibility? His conclusion would actually be quite no. No, and he can't really state it more clearly, no large comparative study has shown a protective effect of stretching. We have to kind of jigger the information, conduct the meta-analyses to get something even statistically significant. They also found a mild negative effect of stretching on strength and power performance in the short term. I'm sure most people here have heard of that. Now, Woods et al., that same study I talked about earlier with one study for warm-up, finds strong evidence for an injury-reducing effect, but when you look at the exercise selection or the study selection principles, you see the difference in study quality and inclusion as to whether or not you come to these effect sizes. And then, of course, it gets super complicated. So that negative effect, if I stretch and then do a vertical jump, my vertical jump goes shorter. 90% of the time, they literally have them, okay, do your stretches, hop here, do your jump, okay. Nobody does it like that. Nobody goes to train, immediately jumps to their 1RM right after stretching. And anytime you actually add a warm-up period in between, those changes disappear. So it's probably not going to hurt your training. Schreier wrote a letter to the editor in response to Thacker et al., looking at, he basically said, so take one of your studies, take this study over here and that study over here, compile them all together, and there might be a positive effect, there seems to be a positive effect for daily kind of regular stretching as a maintenance routine, but negative or no effects for stretching in the vicinity of your workout. Not plausible enough evidence. The evidence isn't good enough to prove conclusively, yes, that is true. He does offer another alternative compared to what we usually study, and then the movement as stretch. When we squat, we are stretching. When we deadlift, we are stretching. We are taking the tendons, ligaments, we are taking the tissues, approaching their end range of movement. That is not addressed in research at all, and I don't know how you would. So conclusions, I'm not convinced it's really strong enough to justify it. If somebody says, hey, I need to stretch, well, if you need to stretch psychologically like it makes you happy, okay, but I can't justify that with the evidence. Routine, non-fatiguing stretching yoga away from the training bout, it definitely won't hurt. It might help. Not the end of the world. If it relaxes you, great. Now we get to the fun part. I can kind of blow through these sections, but there's entertainment here. So cryotherapy, we have ice directly applied, and we have what we call cryosaunas or cryo boxes, where they put you in, they use liquid nitro to drop you down to -60 or -110 degrees, usually is what they use. So with ice application, a bunch of different studies and reviews. A couple things that we see. Exercise plus ice found to be effective post-strain and post-surgery, so that's acute injury. Krautler et al., there are oftentimes, I had no idea this was a thing, I was informed of this, but there are compressive devices used, usually proprietary, usually expensive as hell, to hold ice to you in a proper configuration. There's not a great deal of evidence to suggest that that's any more effective than just applying the ice directly. But it gets the patient out of the way, it puts them off on the side, they're in the machine, they think they're getting something really cool. Guyot et al., some evidence for chronic use in rheumatic diseases and reduction of pain. And this is something we see a lot, pain being this very biopsychosocial thing. And then Ramos et al., in vitro, it mediates inflammatory processes. This is the big thing here, it doesn't interfere with muscle remodeling. So if people say, well, is icing gonna hurt me? Am I going to lose my gains because I ice after each training session? Probably not. In terms of straight ice, some evidence for a small effect for ice, and definitely as an adjunct for pain. Feels like you're doing something that's cheap, why not? That's up to you. Cryosaunas. So I pulled 17 different studies from companies advertising these studies prove what we're doing works. This is my evidence. I just pulled a representative sample here. Porno et al., 11 subjects. They didn't blind. They controlled against themselves, so they did a test, they did an exercise bout, and then checked biomarkers. And then a month later, they did the same bout, the controls were the intervention, then the intervention were the controls. Only biomarkers, no measures of anything useful. Most of it wasn't significant, and there's huge variance in the resulting data. Like when you look at the ranges on the plot, it is absolutely absurd. And you can jigger those numbers to create statistical significance. I don't buy it. Braun, 55 subjects taking 15 sessions. No control again, no blinding. A quarter dropped out. So these were 55-year-old patients who just decided, you know what, screw this. I'm not sitting in negative 110 degrees and freezing everything off. Why? Statistical significance, no clinical value. Hervonin et al., that was meant to be 40 or 50 in each group. This is the one thrown out most often because it says, and it was supposed to be a high representative study, that this works. Originally, they were supposed to have 160. They ended up with 60 because they couldn't get people with RA and older in a hospital to subject to the study, and they kept taking them in trickling based on what they could get. So how powered is it? They had to reduce from 4 groups to 3 because they didn't get enough people to make a basic power calculation in it. And their eventual conclusion is that they all worked for reducing pain. None of them really worked for reducing, they all worked slightly. There was a statistically significant, not clinically significant change in inflammatory processes and the actual disease progression. And the only one that was different from just putting on straight ice was the negative 110 degree room, but it's super expensive. So you're using this as evidence for your product when the researchers literally say it's not cost effective, we don't think you should do it. Conclusions, if it's effective, it's no better than just putting ice on your joint. It's really expensive, it's novelty, it's fun. And if somebody comes, see, there's so much, it's a wall of studies all saying it's effective. It's a lie. Next, NSAIDs. You think, okay, they're highly inflammatory diseases. Every case of rheumatoid arthritis, osteoarthritis has some level of inflammatory cascade involved. So let's just reduce the inflammation. You can talk about 2 things. Do NSAIDs reduce osteoarthritis or any of these pathologies that we've been going over? And do they hurt your gains? Because after all, inflammation and the muscle remodeling process are part of muscle hypertrophy. So there's a big discussion, don't take your Advil. Don't take ibuprofen, it'll interfere. So first things first, it's actually really well researched. The problem is that we often think of NSAIDs as a single category, and everyone thinks, ibuprofen, that's my NSAID. It's like mentally what's in our head, when in fact you have, in one study, for instance, they reviewed 8 different NSAIDs for its effect, and that's this one. Ding, 2002, all over the place. So they took tissue samples, subjected them to the medication. Some NSAIDs damaged the collagen matrix. Some appeared to help. Some had no effect. So diclofenac, they went all over the place in their effect on the collagen matrix, just in situ. There are some animal results that showed promising data, and I don't mean promising by good. I mean promising is it actually gives us data that is consistent. Because these medications appeared to always help, these NSAIDs appeared to hurt. But at least they were consistent. They gave us good data. And then we try that to humans, and we're right back to the grab bag, where when you look at biomarkers, when you look at any kind of metric, you get no consistent measure that this one works. Deep et al., 89 patients replaced their normal pain medication with diclofenac on slow release or placebo. 38 patients didn't finish from 89 because they hurt. It either wasn't working, it was placebo, or it wasn't working because it's diclofenac, we don't know. They left the sample. So 35 reported a 20% or greater pain reduction, but they're in both groups. And there's a statistically significant effect, but we're not sure. And then there was no radiograph or clinical improvement that a doctor could tell in 70%. Now, effects on strength. There is a plausible mechanism whereby NSAIDs would reduce strength. There are cyclooxygenase. There are cyclooxygenase inhibitors, or some of our primary NSAIDs. They are involved those get broken down into prostanoids. They regulate muscle protein synthesis. So if you block the one, you're going to block downstream. I'm not going to go too deeply into this because Dr. Sullivan has an article called Stopping the Spread of Misinflammation. Why he goes over it. Once you get past the in vitro data, which is plausible, and some of the animal data, which is plausible, once you get to people and actually measuring real values, acute and chronic NSAID use doesn't appear to have a negative effect on hypertrophy or any measure that we actually care about, like strength. In fact, Trapp et al. Measuring geezers doing their research sets found that they got stronger than the control group in using NSAIDs. Because after all, if we're looking at 25% of the adult population or 20% of the adult population being diagnosed with an inflammatory condition, maybe not being so inflamed isn't a terribly bad idea. The general recommendation being use it to control pain, don't use it if you don't need it. It seems relatively common sense. Supplements. Everyone wants to take something. In general, I have to say that this research is being done in a lab. So when somebody is conducting research, when they're doing it, they have a tertiary provider who is supposed to be ensuring quality control that the substances are exactly what they say, that they have the amount that is in it. Your Walgreens does not have a lab. There are so many studies that have been done on the amount of fillers, on the number of herbals especially, which have zero detectable genetic content from the herbal to which it says is in the pill. So translating from effective research to effective practice literally cannot be done unless you can find some way to do quality control. Natural is not the same as effective. We're going to talk about that when we get to curcumin, and I'm not even talking about the naturalistic fallacy, like, oh, it's this or that. No, I mean, you can find a compound that is effective, but not in nature. It has to be modeled somehow or changed in order to be useful. So that person who wants to, chug turmeric, like turmeric juices or shakes, we're going to talk about that. Research is tailored towards generating a saleable product. Yay. Glucosamine chondroitin, TLDR, the evidence is not good. Wandel et al. Gets a little snarky. He actually, this whole group comes across as very sarcastic. They did an analysis of 10 trials. They found little statistical evidence, no clinical significance, and at one point they even go, this is such crap. There's a study that would fix this problem, and we think it's being done right now, but good luck. Reichenbach et al., 2007, found an effect in the majority of studies. So if I just go down the list and it's like plus, 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 minus, plus, 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 it looks like there's a positive effect. When you only factor in the highest quality trials, so when you raise the standard, the bar, it drops below statistical and clinical significance. Michellinden et al., they're partially doing a review of the research as quality and found that it's ugly. There's some, using a forest plot, they did a publication bias analysis, found high suspicion of publication bias. Again, it's a very testy kind of statistical analysis, but the idea is trying to identify if there are studies that were pulled off the floor before they were even published because they showed negative findings, and even knowing that there's probably a high likelihood of a balancing effect from material that was never published, they still only found a small to moderate effect for glucosamine chondroitin in reducing arthritis symptoms, arthritis presentation, or pain. Finally, Franson et al. Remember I said that Wandel was like, hey, there's this great study being done that might answer this problem. That's Franson. 2x2 design, 600 participants. It was blinded. Everything looks good quality. They had glucosamine, chondroitin, both, and a placebo group. All 4 improved pain. No significant difference between groups in pain after in the short term. After 2 years, there was a small trend towards glucosamine chondroitin in reducing pain at 2 years, very small. My conclusions, it might do nothing, it won't do much, it's cheap. You do you. It's kind of your choice. There is I'm gonna leave it there. Herbals, Boswellia serrata. There are some findings on this one. Virtually all the research has been done in India in the International Journal of, I can't remember off the top of my head, but Vishal et al., 2011, that Boswellia serrata, which is called Indian frankincense, compared favorably to placebo on function and pain measures in osteoarthritis. It was blinded, it was randomized. When we look at the study quality as written, if it was actually done as performed, it seems pretty good. Gupta et al. 2011 shows an incredible relief of symptoms. 100% relief of all back pain. 70% relief of total pain. Just all over reports and presentation of pain. There's a lot of sketch in this study in terms of its methodology and its reporting, and I kind of wanted to point that out. There's Sengupta et al. 2008, so we're going to get to Sengupta again here in a second. Good reported methodology. It's a dose-dependent asymptotic improvement in OA. So they did multiple doses. They found that you get to a certain point and you don't seem to get any further improvement. Fantastic. That's what we would kind of expect to see in a medication. Here's the problem. Big Pharma has already got its hold on it. Boswellia serrata is already a manufactured medication, eflapen and 5-loxin. So they've taken Indian frankincense, they've added different components to it to make it more bioavailable. And this study, aflipan appears to have more effect at the same dose, no worse side effects than placebo. Big Pharma doesn't want to kill you. They don't want to hide it from you. They just want to sell it to you. There's another issue here, which is high likelihood of interference from the pharmaceutical companies itself. Every one of Sengupta's studies, because that particular researcher is involved in multiple of these, and they're usually named as the primary, says no conflicting interests. So I just, curious, looked them up on ResearchGate. They belong to, I think, Lanai Nutraceuticals. They're a researcher with that company. You get conflicting interests. And there's no way to really identify what those would be. Curcumin, also known as, or also part of turmeric, it is a component in a curcuminoid. Manufacturer-funded study of Meriva in 2010 in Italy showed improvement in pain and functional scores. A lot of sketch. It actually is presented, the research study is presented as a brochure, like, see how awesome this is, and it's manufacturer-funded. DePero et al. Compared acetaminophen, Meriva, and nimesulfide, which is another NSAID, for pain relief and side effects, found it as effective as acetaminophen. And then, I'm not going to try to pronounce that, I apologize, compared it to ibuprofen, performed equally well with fewer side effects. There's a sketch in terms of methodology there. The thing I want to point out here is that Meriva has phosphatidylcholine as an additive to make the turmeric more bioavailable. There is suggestion that you would, so 500 milligrams of Meriva is, or I think it's 200 or 500 is the dose. Even if you got 4 grams of curcuminoids, not turmeric, because curcuminoids are only a subset of turmeric. If you were to get 4 grams of curcuminoids, you would have less bioavailability than they believe would be clinically significant. So again, we're in the loving hands of Big Pharma. Fish oil, almost getting to the end. So a lot of people take fish oil. There are a lot of purported benefits in terms of heart disease, in terms of we need to keep a 1-to-1 balance between omega-3s and omega-6s because our Paleolithic ancestors did, and don't even get me started. I'm just talking about joint pain when I'm looking at these. Ariza et al. 1998 reviewed trials that only had high quality, it is impressive that there's enough research done on this that you can actually do that and come up with data. Small evidence of statistical significance, clinical significance uncertain. Unfortunately, that's what we get in a lot of this. Calder et al., newer research, so it adds more to the reviews that have been done before, confirms the plausible mechanism, statistically significant, clinically negligible again, and then Goldberg, meta-analysis of 17 trials. Small to moderate, positive effect size, and definitely a positive statistical significance. There's only 2 things I'm going to mention about fish oil. One, the proposed mechanism of action is that omega-3 fatty acids are anti-inflammatory, whereas omega-6 fatty acids are pro-inflammatory. And they compete for the same cellular receptors for action. So if you, one of the things that kind of confounds these, and there is no way to get around this confounder, is could we just correct this with diet? You know, if I take out the seed oils, the salad oils that are high in omega-6 fatty acids, if I completely remove those from my diet and just ate a couple of fish, would that produce the same results? That is not studied and not nearly to as high quality as we would need to come up with a firm answer to this question. Also, fish oil, in terms of my conclusion for it, for joint pain, it's one of those things where, just like glucosamine, chondroitin, and a couple other things we've talked about today, if it has a big, it's kind of like steroids. If it has a big enough effect size that you notice, then either people aren't asking the question, you know, they're not trying to do research and finding small statistical effects, or it's a pharmaceutical, and it's going to have side effects. So in many of these things, we end up with statistically significant, might help, probably help, consider the costs, consider the quality out there in the market, decide for yourself. But if it helps, if it does, it's likely to be a small to moderate effect size at best.